Thank you so much. We have someone that will be joining our panel virtually, but I guess it's time, Scott, you can come back up, and you can come right back up and have your seats. And we're going to introduce Axel Vanderperre, who will be joining us virtually. He's right there. Okay, I'm going to give an abbreviated introduction to him as well. He has a long career of more than 30 years in medical and pharmaceutical industry, clinical research, and communications, and has moved to achieve certain goals that he had to join different HIV patient organizations to develop a not-for-profit organization, Utopia, BXL, with focus on identification of needs, expectations of aging people with HIV, and the creation of educational projects with added value and innovation to the aging community. He's the coordinator of the Positive Council in Belgium, an active member of the EATG, European AIDS Treatment Group, and founding member of the International Coalition on Older Persons Living with HIV. And we're going to give him a chance to say a few words, and then we're going to open the floor also for Q&A, because we have a challenge. We're overtime, okay? And we want to make sure some of the questions are answered. Some are on virtual and some are going to be in the audience. So is that all right if he just gives a few words at this time? Axel?
Yes, well, I'll make it short. It's so great to be in this workshop. Last week I was in a European conference on HIV, 3 days, and I have the impression that on one day I got even more data to digest than 3 days in Europe. And obviously there are quite severe themes like mental deficiencies, chronic inflammation, but I took some positive messages from this workshop. One is animal therapy in long term has the largest effect on long term in loneliness. And in fact, I was hesitating already 3 years to take a dog, and I think your workshop will motivate me to do it. Then another aspect is, okay, I'm a long-term survivor. I had AIDS. My CD4 cells were very low. I survived. I got a good career. I have a lot of comorbidities, which were not assessed in time. But there is something positive what I hear as well at the workshop is what I hear, neuronal plasticity. And I think that if you are engaged like in a career or within HIV association, this could be a really study. What is the influence of engaging as a patient advocate in your mental health? And I'm sure this helped me. And obviously, I would like to go to a HIV center like run and developed by Dr. Guaraldi, because I must say, I'm in a rich country, but the model of care still has to be improved. And with this, I end my small talk.
Thank you. So, question one.
Okay, thank you all. Alan Winston from London. Thank you all for lovely presentations. Scott, a question for you, if that's okay. So we know that the integrase inhibitors are all associated with insomnia, and the Beck Depression Index has quite a few sleep questions. So were you able to look, is sleep driving this, or is it a sort of, are people ticking every different aspect of the Beck Depression Index? Thank you.
So we didn't do those analyses. We certainly can. The subscales that were most affected were affective and apathy. And I think the sleep questions come under somatic. So my guess is that sleep won't be driving it, but we're totally happy to go and look at those items and you know, if you report back. So if,
Mike 2.
Haley from Colorado. Marie, I was wondering how you would describe the comparison between BCAM and things like MoCA or other existing screening tools, and what, I don't know, have you looked at any differences or things like that?
So the MoCA is, the MoCA was developed as a screening tool for mild cognitive impairment, and what tends to happen is people use it as a measure. It wasn't developed as a measure. You should be looking at the cutoff. You're above cutoff or below cutoff, end of the story. But people use the score, 27, 26, 25, as if this were a calibrated measure, and it's not. It doesn't have the psychometric properties to be used as a measure. So this is what we did differently. We took statistical approach from the field of measurement. This is a measure from the start. So it's in the way, I mean, you can see the tasks. The tasks are nothing unusual. And in fact, you can take the tasks from the MoCA and combining using rash analysis, except that you're not supposed to for copyright reasons, but we've done. So, but the MoCA is too easy. We know that from HIV. So one of the challenges when we developed the BCAM, we've been optimizing it for the past 10 years to find tasks that are able to measure at the higher end of the spectrum, because that's where you want to measure. So it's not so much in the tasks, it's how the tasks are combined to come up with a legitimate score that can be used for mathematical properties. You can subtract and you have a legitimate difference.
So microphone 1.
Thanks to you all. Marie-Josée, the BMI finding particularly caught my eye. I think there are lots of studies that show no effect, but I've never seen a study that showed the opposite effect. And it wasn't insignificant, it was a fairly large effect. The only studies that I do know of are people who are older, where increased body mass index tends to have a protective effect for unclear reasons. And I'm wondering if there was an interaction between age and BMI with respect to cognition.
We were surprised, whether it's because it's somehow an indicator of socioeconomic status, that it shouldn't be that big. But when we put age in the multivariate model, it remained significant. So we're going to have to be looking at that in more details, but it is puzzling and unexpected. And certainly not the message that we want to give, but it is what it is. There doesn't seem to be an interaction.
Microphone 3.
So can I just elaborate for a moment? So I thought Dr. Ellis might remember that our senior colleague Alan McCutcheon and Fred Sattler, using the original charter data in what was originally a lipoatrophy sub-study, looked at the anthropometric correlates of neuropsychological performance. And I think, Ron, I hope I'm not misremembering, I think they found that BMI was protective, but that waist circumference was not. And once they put waist circumference in, which was associated with worse performance, the BMI effect went away. And the rationale was, BMI is just based on how heavy you are. And we have people who work out a lot sometimes and have more muscle mass, which weighs more than fat. And so I think Ron's point about age is an excellent one and is probably the most likely explanation. But I think an alternative one is that people with more central obesity perform worse, but BMI captures both them and people who have more muscle mass as well.
So we have the data on the waist and hip circumference, so we could look at that, and I will report back like you do.
Thanks. So microphone 3.
Oh, hi, Simon Collins again. It's a couple of direct questions about the dolutegravir studies. Did you account for timing of the doses? Because some of the early studies reporting CNS symptoms were with people taking it at night rather than in the morning, and that disappeared when the dose timing was changed. And I guess, would you expect to see similar impacts from bictegravir, which has such a similar chemical structure?
Yeah, I've been surprised at some of the reports on the differences with bictegravir as well, because they are so similar. We did not look at the dosing time, but we have those data. We collect those data, so it would be an easy thing to do, and be happy to do it. I'd be interested myself.
I'm going to take one of the virtual questions that came in. And Scott, this is for you from Jules. He says, Scott, is that related to higher drug levels in older people with HIV when you were talking about dolutegravir?
We did measure drug concentrations in specimens collected as part of the Charter aging study. Chin Ma from University of Buffalo and his postdoc are analyzing those, so I've not seen them. But that's now the third thing I can look at. And also we got the Pittsburgh Sleep Quality Index too, Alan, so we could also look at that. But we can look at sleep, we can look at dosing time, and we can actually go and look at the concentrations in blood joules also.
So microphone 1.
Hi, Joe Margolick. So for Marie, I was interested in the hemoglobin effect. If I understood the data correctly, a higher hemoglobin was associated with cognitive decline. And you can correct me if I'm wrong, but it looks as though that persisted in your adjusted model also. I wonder if you have a idea why this is. For example, does it possibly indicate lung disease?
So I think the effect did not persist with age, but it was higher hemoglobin. So whether it's related to lung disease or some other pathological condition was my hypothesis. I'd be curious to hear if people have other hypotheses. Tobacco. We can look at that. Or? Altitude. Montreal.
You're on top of it. No.
Interesting. We have that too. We have the list of medication that people take. It's good. I should be taking note.
Well, we're trying to get right back on time, and there's just a comment. It's no other question, but I'll just share it. Many older people practice healthy lifestyle and still get cognitive impairment. Okay. She says, cut it. So that you can enjoy your coffee break at outside of the meeting room. And don't forget to complete the online session survey, which will be sent by email at the end of the day.
Okay.
15-minute break. 15 minutes.